Hello, everyone. Thank you for joining us. I'm Nikki Bravada, and I'm from Gen Oracle. I'm here in Phuket, Thailand. And together with Sasha from Max Life Compounding Pharmacy, we're really excited to have all of you guys here tonight and, well, in the morning for our hosts and coming from the United States, of course. So thank you for making a early morning to help with education about peptides here in Thailand. We're really excited to host this webinar together with the International Peptide Society and A4M. And we're really happy about that because we recognize that there's a huge need for education about peptides amongst our practitioners here in Thailand and of course everywhere else, trying to raise some awareness. So I'm really excited to also be here tonight with Ryan Smith, who has helped Gen Oracle to become what it is today, to provide these products here throughout Thailand and internationally. So Ryan, I'm not sure if everyone is familiar with our speakers tonight, but I wanted to make sure that everyone knows that Ryan Smith has graduated from the University of Transylvania and is a biochemist. And he also helped start the tailor-made compounding pharmacy back in 2016. And just a few years later, in 2019, they became the fastest growing company in healthcare and really made, I think, peptides really as popular as they are, at least in the United States, and now, of course, internationally. And so we're really happy to have Ryan to have helped us to grow. And thank you so much for being here. And then I wanted to introduce Mr. James LaValle, who is joining us from the United States. And Jim is a clinical pharmacist and clinical nutritionist with a long bio that I was trying to memorize, but never would be able to give all the accolades that I could give in less than probably 10 minutes because he's accomplished so much. And I've been lucky enough to have been taking the International Peptide Society certification course right now and have to say that Jim is one of the most amazing educators that I've ever listened to. I have to rewind and play a lot because it's a lot to digest, but I really appreciate that it's not just about peptides. It's about everything that a clinician needs to look after their patient. And from a very holistic perspective, everything from nutrition to nutraceuticals to peptides and lifestyle. And so we're really excited to have Jim here tonight to teach us more about peptides. And Jim is going to tell us about the top 5 peptides that we can use to integrate into practice. And so I hope that was enough of an introduction to Jim, but if you have anything else to say, or Amy or Ryan wants to jump in and say anything, please do. And everyone else, please put your questions in the chat. We will try to address any questions that are at the end of the webinar tonight. And also it's recorded. So if you wanted to share, we will send you the recording. We will give that to you after. And please just know that we can, answer any questions for you after the webinar tonight. So I'll hand it over to you, Jim.
Excellent. Nikki, thanks for the great introduction. And it's a pleasure to be here. So we're going to get started right away because hours go quick and I've got plenty to go over. And I think the first thing that I want to do is, well, why peptides? For me in practice now, 38 years doing integrative care in multidiscipline clinics. That's basically what my history has been, putting together doctors, dietitians, nurses, acupuncturists, and really developing a whole person approach to their chemistry. The first step that we need to understand is what we're really trying to do is regulate metabolism. And if you had to say what your metabolism is in a non-technical way, it's really about all of the chemical and metabolic signaling that is going on in your body right now for that patient that sits in front of you or for yourself, that drives how you're feeling today or how your chemistry is today. And more importantly, it is creating the chemistry of your future and moving you either towards your future health or future illness. And of course, when we look at this process of metabolism, it's directly under this global metabolic inflammatory signaling, meaning that the term metaflammation or metabolic inflammation drives metabolic dysregulation. So why I found peptides to be so important over the last 6 years, and why I've gotten pretty passionate about peptides, is I think it's an important piece of therapy that goes into your toolkit that helps you to more efficiently regulate people back into their homeostatic or their ability to maintain homeostasis, retard the aging process, help with that, the longevity that people are looking for, and many times combat illnesses that they're and injuries that they're facing. And so understanding the disruptors of current metabolic performance obviously leads to strategies to cut off excessive inflammatory signals and help to rejuvenate your health at the cellular level, meaning that peptides will be signaling cellular changes in the chemistry of an individual. So the one thing I always had to be careful of is I never read about a peptide that I didn't like. And at the same time, I found it to be more efficient to look at, well, what are key peptides that I should be using for this person at this point? And think of it as a roadmap of how I'm going to utilize peptides as I remodel their metabolism. And of course, there's a lot of things that are influencing the aging process. So oxidative stress, obviously inflammatory signaling, hormonal balance, the effect of stress hormones, glucose and insulin signaling, gut integrity, immune balance, which of course, I think if we didn't learn anything over the last 3 years, we're fully understanding now the whole presence of immune regulation and keeping our expression of our macrophages in an anti-inflammatory stance, or our monocytes being in an anti-inflammatory stance. And then also understanding that there is environmental burden. And of course, there's this little piece called genetics and individuality that plays a role in how someone's going to age and how they're going to feel and how they're going to take on various assaults to their metabolism. So when you think of the process of accelerated aging, because in the end, this is really what's happening, right? People end up with multiple influences on their chemistry. And so this leads to, whether you're looking at telomere shortening or, deoxyguanosine and DNA damage, or the movement, of course, especially as we're aging, towards senescence, reducing the process of autophagy, or that ability to clean up waste proteins and waste, byproducts of metabolism from the cell. And then, of course, immunosenescence. And where does that lead us to? Well, it leads us to the major aging, catalysts, right? So cardiovascular disease, damage to our joints and connective tissue, neurologic issues, Alzheimer's, Parkinson's, depression, but it doesn't even have to be that far along. It can be the beginnings of things like, short-term memory loss. I'm out of intellectual power by 2 p.m. The earlier we start to look at these signs, the better. And of course, cancers, and when you begin to understand how all of this plays together, metabolic diseases like type 2 diabetes plays dramatically in the role of cancer. So all of these things are swirling together. And in many times, people end up with several of these issues all at one time. And in particular, probably type 2 diabetes is one of the hallmark examples of that, right? Where they have increased risks of cancers, increased risk of Alzheimer's, increased risk of cardiovascular disease, increased risks of issues like polymyalgia rheumatica, where the connective tissue is inflamed. And so it's really important to begin to figure out strategies of how do we start to signal to support this. And if you think of Metaflammation, you can think of it as this process of a low-grade inflammatory process. And, it leads to these big issues of, insulin resistance and obesity, the byproducts of stress. Diet, of course, has a big influence on this. And then, of course, the breakdown of the gut, or the blood flow to the gut, so that we get the die-off of organisms that lead to lipopolysaccharide release. And of course, lipopolysaccharide, or circulating endotoxin, triggers global inflammatory signaling. And then, of course, there's this kind of what I would say tsunami effect of people with chronic kidney disease, non-alcoholic fatty liver, right? So all of this is under this inflammatory signaling. And of course, we know that this is related to, aging and accelerated aging. And the reason I'm kind of going through this for you, because I think if you start to look at the person's chemistry as this whole process, you can begin to look at, well, what peptides do I apply where? We're going to learn about some big hitters in peptide therapies. We're going through some of the most important peptides, I think, that you utilize in therapies today. So, but if you think about, your body takes on a stimulus, some sort of, damaged cell debris, some sort of, irritant chemical or environmental burden. It could be a biotoxin or a pathogen. It could be stress. It could be changes in diet. In the end, you create an inflammatory response. And that inflammatory response is meant to remove damaged cell debris, remove the irritants, neutralize pathogens, hopefully regulate or bioregulate allostasis so that we don't go into allostatic load. The effect of that is to eliminate the inflammation, switch off the inflammation, and then regress that person into homeostasis back into a healing process. The issue that we have is that people are overwhelmed today with the load that is triggering these types of errant signaling. So when we look at the systemic effects that occur when we get stuck in this inflammatory response, it's pretty diverse. The one that's not mentioned here, of course, would be dyslipidemias, or the increase of inflammatory or damaging lipid particles. So, oxidized LDL, apolipoprotein B, lipoprotein little a, small particle LDL. Just to mention a few, when under chronic inflammatory signaling, those type of lipids start to prevail, which of course creates some stress on the endothelium. One of the biggest effects that starts to occur is that we begin to get sarcopenia. Now, it's enough that as we're aging and we lose our capacity for, our natural growth hormone release, which of course is going to make us a little more catabolic, we accelerate the sarcopenia because of this lack of dynamic muscle perfusion. And in fact, under chronic inflammatory signaling, we begin to lose our smaller microcapillaries. That's in fact due to damage to the glycocalyx, or the inner lining of the endothelium. And then we start to downregulate signaling of IGF-1. This brings up a really big topic of, well, there's literature that says that lower IGF-1 is good. Then there's literature that says that, wait a second, I should have IGF-1. The reality is that we want people in a homeostasis with their IGF-1. Excessive IGF-1 signaling has been shown, repeatedly in type 2 people with type 2 diabetes, that it can signal abnormal cell growth. So excessive IGF-1, sure. But for the most part, what happens is people end up suppressing their IGF-1 signaling and therefore cannot get anabolic. The next piece that happens is you start to see anemias like hepcidin upregulation, which then leads to a downregulation of ferritin. So you'll see in many times maybe a normal iron with a very low ferritin, or low iron and a low ferritin. And yet, the person doesn't have a bleed and they're not anemic, but they're not able to absorb or utilize their iron and or ferritin. And therefore they can't make EPO, and EPO signaling is altered. Probably one of the most important aspects of metabolic inflammation. And when we talk about MOTS-C today, insulin resistance. So as we upregulate inflammatory signaling like TNF-alpha, also interleukin 6 is big at this, just wasn't listed in this particular graphic. We start to lose insulin receptor signaling 1 and 2 activation. And what that basically does is that forces people into aerobic glycolysis, where it becomes very inefficient. You make more lactate, you make more pyruvate, you lose ox-phos relationships. And the net effect of this is you're now making 2 packets of ATP as you're entering a 1 glucose molecule across the cell instead of 38 packets. So energy goes down, the insulin receptor is no longer working. At the same time this is going on, with the influence of these inflammatory cytokines, we start to see an increase in osteoclasts, a decrease in osteocalcin, and therefore bone loss. And then probably as we begin to really drive closer into deep damage, we see neurogenesis start to be inhibited because we lose neurogenic growth factors, we lose neurogenesis and cell plasticity. And this is pretty clear because the stem cell for neurons ends up being inhibited from its progression to a fully developed, neuron that's dendritically pruned and able to function, because inflammatory cytokines will inhibit by attaching to that stem cell and inhibit its growth. And really, when it boils down to it, it's all about the fact that mitochondrial function and biogenesis is inhibited because of this change in the way insulin receptors are functioning, because of the reduction in the NAD to NADH ratio, because of the fact that we're losing signaling for mitochondrial renewal via PGC1 alpha. All of a sudden, we have an individual who is metabolically they're stalled. They can't make energy. They can't create cell renewal for their neurons. They suffer from poor oxygen. They're catabolic, and they end up in this chronic inflammatory swirl that ends up leading to chronic illnesses. And so, I've already kind of mentioned these, but this is kind of the resulting, comorbid conditions that occur, right? Which is basically what I went through. And then it's important to understand the immunometabolic aspect of this, that as we trigger immunometabolic dysfunction, we start to lose the ability of regulation of our T killer cells and our natural killer cells and our complement pathways. We begin to trigger the inability of the immune system to be, regulatory. And this affects everything from, at a cellular level, but, even as people are gaining fat, obviously, and the adipocytes start to, produce adipokines as they take on more and more fat tissue. And, one of the biggest aspects of what we can try to correct, and if you note here, we can see that these cytokines, TNF-alpha, IL-1, IL-6, upregulated, causing an effect in the liver, leading to non-alcoholic fatty liver. Layering of more fat into the skeletal muscle, triggering inflammation in the pancreatic islets. This all leads to this concept of, developing or evolving type 2 diabetes. And as we know, in many cases, type 2 diabetes evolves over a decade or more. It's a slow slide to the development of type 2 diabetes. And, the purpose of this is just to really understand, why am I trying to use peptides? One of the biggest things that, I'm seeing more and more in practice is the fact that more and more people are showing up with reduced kidney function at earlier ages. And that's because of unregulated inflammatory signaling, the loss of autophagy, which then increases endothelial dysfunction, cardiomyocyte fibrosis. And then, of course, we get dysfunction of the glomeruli, and the increase in fibrosis dysfunction in the tubulointerstitial tissues. So the net effect of this, as you can see, is still due to increased reactive oxygen species and the inability to neutralize that and repair. So with obesity, incredibly important that we start to look at how we can utilize peptides to regulate an individual, because as we increase the load of visceral fat, we trigger more M1 macrophages in the adipose tissue, and M1 macrophages, of course, increase TNF-alpha, IL-6, C-reactive protein, IL-1 beta, just to mention a few. And we decrease the anti-inflammatory cytokines. So the M2 macrophages, you end up down regulating IL-1RA, interleukin 10, adiponectin. Of course, adiponectin, a great marker to look at And so the net of this is that, as we see people that are gaining weight, becoming insulin resistant, they're triggering a global inflammatory response, hence why we're going to talk about TA1 and TB4 today. And I added these slides this morning, actually, because I think it's important to realize that as we increase pro-inflammatory mediators in the body, we're altering mitochondrial function. And basically, we'd end up with ragged mitochondria and the signaling of less mitochondria. So we lose mitochondria, we have less efficient mitochondria, and that, of course, increases the effect of aging, which I look at aging as a disease. So when we look at what's called DAMP molecules or damage-associated molecular patterns that are derived from the mitochondria, that triggers more inflammasomes, hence why it's important to trigger autophagy. So when autophagy is inhibited, we can't clean up or turn off inflammasomes, principally, the NLRP3 inflammasome is, incredibly important in terms of triggering chronic inflammation, which leads to accelerated tissue damage. And literally, it affects all tissues and organs. So autophagy, important, hence why everybody's into time-restricted eating these days is into induce autophagy. That's one way to do it. The other way is to regulate your cell and return it to homeostasis. And so this is the NLRP3 inflammasome activation. And of course, when that gets activated, you upregulate NF-kappa B. And NF-kappa B is, of course, the mother signal for inflammation within the cell. And another piece is that, elevated homocysteine just isn't a matter of being low in folate, B6, and B12. Homocysteine is a great marker for inflammatory signaling as well. Many of you have probably seen you've given people B vitamins to try to lower their homocysteine, and yet the homocysteine doesn't come down or comes down very little. And that's a sign that they have more global metabolic inflammation is taking place, and therefore the need to look further or go deeper into the toolkit to balance inflammatory signaling. And of course, we talked about that. So let's talk about peptides now, the purpose of our talk. So what are peptides? Typically short chains of amino acids, less than 50 amino acids. They don't, tend to trigger an errant immunologic response. Probably the most famous peptide, of course, insulin. So everybody, peptides are in the drug pipeline, and there's many of the peptides that are entering into the market, and I think they're going to play a huge role in therapeutics over the next decade. And so when you think of current uses for peptides, literally, and I'm so happy that Ryan's on because Ryan was a real pioneer in bringing this information to bear in the US. But literally any process in your body that needs to be regulated gets regulated through peptides. Peptides are made by your body, and are made by your body in order to induce that homeostasis, but either by aging or some sort of inhibition, as I went through earlier, we no longer can create that signaling. So if you look through this slide, it's very easy to see that, if we could regulate all of the things that are listed here, from the ability to have improved antimicrobial effects, the antioxidant abilities, the anti-obesity abilities, the ability to regulate, lipids or metabolic inflammation or repair the gut lining, all of these play key and critical roles. Of course, we've got time for go over a few peptides, but man, it's exciting, and it's the whole reason for the International Peptide Society is to get more and more practitioners not only familiar with peptides, but how to use them with clinical excellence. And this is just kind of a 2016 slide showing percent uses of therapeutic peptides. And if you see, the biggest areas being on metabolic disorders and immunologic disorders, but really across the board, a lot of peptides that are being utilized across a broad array of categories. So the first one we're going to talk about is MOTS-C, or mitochondrial-derived protein. It's 16 amino acids. And this is probably, for me, one of the key peptides that I utilize, especially here in the US, because there is such a prevalence of type 2 diabetes and insulin resistance. So what MOTS-C does is it helps to preserve mitochondrial function and the viability of the cell to maintain its energy capacity under stress. So if you're familiar with a term called cell stress response, so there's the cell danger response signaling theory by Navio, which basically is very similar if you're familiar with Reckwig's work in the 60s, was that the more that we experience load or signaling that's disordered into our cell, the deeper that stress response disrupts our cell signaling. And the key target for that, of course, is mitochondrial function. So what are the big targets you think of with MOTS-C? Is, first of all, metaflammation, of course, because it's going to help with regulation of mitochondrial energy and therefore energy utilization, ox-phos relationships, getting a person out of aerobic glycolysis. So it's effective in supporting glucose and insulin regulation. Obviously, we look at chronic degenerative diseases, and mitochondrial issues are associated with that. So we can consider it an anti-aging compound, but more importantly, I look at it as a longevity compound, because I still can't find anybody that goes from my age, 62, back to 20 or back to 12. I may look pretty good on my labs, but I'm still there. So I like to think of longevity. MOTS-C, the levels decline with age, and they decline with age, and they, probably one of the most interesting aspects of this was the pandemic, because of the disruption in the utilization of NAD, right? The cell gets rapidly depleted of NAD, which then induces that cytokine storm. So MOTS-C is important because it regulates, nuclear gene expression. It regulates skeletal muscle metabolism, so that process of layering of fat into that insulin resistant or person with diabetes muscle. And then it also helps with myoblast adaptation to metabolic stress. So incredibly important from that perspective. Involved in glucose control and cell survival, involved in protecting the kidney. So we see that reduced skeletal muscle expression of MOTS-C in chronic kidney disease is also correlated to reduced serum levels. And then, of course, in type 2 diabetes, where you have complications, you can see that MOTS-C could be incredibly important. So for me, I'm using it in anyone where they've got evolving insulin resistance. And you have to remember that by the time a person is in the third quartile of a normal blood glucose, so they're in the upper range of normal, they already have disrupted mitochondrial dysfunction and endothelial dysfunction. So don't wait until they become a person with diabetes or a person that's fully insulin resistant. Take a preemptive strike to create cellular repair. And so I use it there. Also, I use this with weight loss because I get fat loss with the use of MOTS-C. And then I think it's important just in any of the chronic degenerative diseases and neurodegenerative diseases that we're upregulating, improving mitochondrial function. So increasing intracellular NAD levels and mediated by SIRT1, what's that mean? Well, it means we're going to be signaling for mitochondrial repair and mitochondrial biogenesis when we upregulate SIRT1. And of course, this process of NAD levels being upregulated is important because as we age, we lose our ability to take niacin into the cell and create effective NAD levels, and therefore have to find other ways like this, going through the scavenging pathway for getting niacin in via using something like nicotinamide riboside. But the net effect is this aspect of improving insulin sensitivity. So it has a lot of different impacts on everything around insulin regulation. So probably, I think one of the most important is this first bullet point: increasing glucose utilization, meaning that I'm going back to that 38 packets of ATP instead of 2 packets of ATP, and I'm restoring fatty acid oxidation, or the fact of OX-PHOS functionality. In many cases, people that have upregulated their glucose and insulin tend to end up upregulating their cortisol, which ends up downregulating their thyroid production, their thyroid hormone production. And of course, thyroid hormone, incredibly important for the carnitine-palmitoyl carnitine pathway for burning fat. We activate AMPK, of course, important for metabolic regulation, for energy production and sirtuins, and actually upregulation of PGC1 alpha, and then increases glucose uptake into the muscle cell to be utilized. You get this upregulation of thermogenic gene expression, so we're burning fat more effectively from gene expression, and then upregulating brown adipose tissue, which of course is more efficient, and then getting rid of white adipose tissue as well. So where's its use? I think I've already went through this, but I just want to emphasize meta-inflammatory conditions, obesity and weight gain, type 2 diabetes, insulin resistance, anti-aging, longevity. Once again, we do pretty good till we hit 64. Then all of a sudden the senescent cells start floating around, right? So we want to end up trying to prolong that time in which our cells are efficient. It is cytoprotective, and of course, it helps with mitochondrial dysfunction. You also may think of this in people who are exercising very frequently. They tend to create a lot of mitochondrial damage, right? You're measuring things like creatine phosphokinase. You're looking at their efficiency of their mitochondria, because people that are, for example, endurance athletes are prone for this. Dosing, and there's a lot of different rationales to this. This is the typical dosing that we utilize of 5 to 10 milligrams twice a week, which is kind of nice that you don't have to use this daily. I really haven't seen any issues around the application of MOTS-C with any of our patients. In general, very well tolerated. This, of course, was published in 2015 in Cell Metabolism with the title of Mitochondrial-Derived Peptide MOTS-C Promoting Metabolic Homeostasis and Reducing Obesity and Insulin Resistance. So MOTS-C, incredibly important. And I will get to your chat questions. I'm going to try to do those at the end. So when we look at this, MOTS-C is upregulating AMPK, which of course is incredibly important. This is just kind of a summary slide, which we've already been through, but it nicely depicts this. And Amy, I will send these slides so that everyone can get these slides as well. This was a phase 1 trial, a 1B trial, 4-week multi-center randomized double-blind placebo-controlled trial in patients with obesity and non-alcoholic fatty liver. Significant reduction in ALT and AST. If you look at, down 21% on ALT, 28% on AST. Significant reduction in glucose levels at 6% compared to the placebo, and a trend towards decreased body weight after 4 weeks. And look, this is a 4-week study. When you're dealing with somebody with metabolic disruption, where they are, they have obesity and they're already, have non-alcoholic fatty liver, it's going to take some time, right? So, I'd be interested to see what happens at 6 months in a controlled trial. So, next peptide, thymosin alpha-1. So, thymosin alpha-1, also known as Adaxan, it is a patented pharmaceutical version. Typically, it's used for hepatitis B and C and HIV. It's immunosupportive and modulates the innate immune system. So this is really important. Immunomodulation for me, and I've worked with immunomodulators even on the nutrition side. So plant sterols and sterolins were developed, were actually back in the 50s initially, named Harzol. It was for BPH, but then in Africa, they started looking at Th1 and Th2 modulation for HIV. And so Why this is important is that as people begin to be under more metabolic stress or allostatic load, they begin to trigger more Th2 activation or inflammatory activation. And of course, as we saw with a lot of individuals who are chronically in that metabolic inflammatory state, whether it was diabetes, heart disease, that they were more prone in the pandemic to have it, incredibly adverse outcomes because they had this imbalance between Th1 and Th2. Their natural killer cells were deficient and not active. Their thymic cells, so their T killer cells were immature or adolescent. And so restoring that ability to modulate immune response is incredibly important. And then, of course, it helps with modulation of the mucosal immune system in the gut, which, of course, 70% of the immune system response ends up coming from the gut. And of course, we learned a lot about that over the last 3 years as the effect of SARS-CoV-2 on dysbiosis and the fact that it was triggering global inflammatory signaling via the gut, leading to cardiometabolic issues as well as neurologic issues and neuropathy. So where is TA1 thought of? Well, obviously decreasing viral replication, but down-regulating IL-1 beta and TNF alpha. So you have a lot of folks who may have biotoxin exposure where they've upregulated IL-1 beta, they've upregulated TGF beta-1, maybe their metalloproteinases in their connective tissue have been upregulated. So in the connective tissue matrix. So important from that perspective. And then, of course, increasing maturation of T cells into the CD4 and CD8 ratios improving. This, of course, incredibly important because we're finding out, of course, that immune aging is incredibly important as we get, the effective T killer cells to basically neutralized cells that no longer are able to support defense. And then if you look at the other block here, increasing IL-2, IL-10, interferon gamma, IL-12, and interferon alpha, this is supporting that M1 macrophage activity, inhibiting M2 and balancing out M1 so that we have an appropriate response to any insults. So when you look at thymosin alpha-1 and what it's doing is it is working to neutralize or to regulate NF-kappa B. So the net effect of this is improved stem cell differentiation. We get cytokines that are activated, but appropriately activated, right? I mean, TNF alpha is important to fight off a bug, just not excessive TNF alpha expression. And then, of course, the number of natural killer cells and the expression of macrophages in the M2 phenotype, all coming as a byproduct of TA1 immunoregulation. So 3,000 patients, 70 clinical trials used in conjunction with vaccines to support immunity. What's the typical dose? 0.15 mLs daily on a 3,000 microgram per ml dose. I've done 0.15 a couple times a day, especially when I'm dealing with certain autoimmune situations. You may see a transient increase in ALT. It typically ends up, reverting back to normal relatively quickly. But initially in therapies, I'll usually do this twice a day, and you can probably push this dose even a little more. I've had clinicians at 25 units subcutaneously twice a day, initially. And I added these so you can go through them. As I said, I'm going to provide these slides for you. So these are just all of the various studies that have, highlighted the effect of thymosin alpha-1. I'll leave you to be able to to be able to review these. I think one of the interesting ones, if you look at down here towards the bottom, the significant decrease in mortality due to multiple organ failure in patients with sepsis, incredibly important. Then, of course, improving CD4 counts and not just improving CD4 count, but improving the functionality of the maturation of CD4 cells so that they're more functional. And then, interestingly, it activates and amplifies, catalase, SOD, and glutathione. So incredibly important that we see that it's helping to decrease oxidative burden. And once again, more studies just showing the inherent value of TA1 therapeutically. TB4. So Thymosin Beta-4, it occurs in most cells. It's 43 amino acids. It's in higher levels in platelets and white blood cells. It helps to decrease scar tissue formation and reduces the level of myofibroblasts. Obviously important post-surgically, important in tendinopathies and tendinosis. So in addition to the fact that it's antimicrobial and it helps with T killer cell function, actually a nice combination with thymosin alpha-1, another agent that works in the human gut mucosal immune system. So it's helping to regulate the gut endothelial immunologic reactions. And then, of course, being neuroprotective. And even though that was derived in experimental models, I have a case right now of someone who had basically almost lost their leg in a jet ski accident. And, it was, had a lot of neuropathic pain. And over the last year and a half between the application of TB4 and other peptides, his leg was saved due to multiple surgeries and fantastic acute care. But the real kind of repair that occurred with him over the last 18 months has been striking due to using peptides, in particular TB4, also use another one called ARA290, but MBPC 157, which we're going to talk about in just a little bit. So don't minimize that value as a neuroprotective compound, because I've seen it clinically. So when you look at the summary on TB4, there's an awful lot to ingest on this slide. People are utilizing TB4 as a part of hair growth strategy. So for people that are, doing PRP and BPC and GHKCU, and they use TB4 as well with hair growth, it makes sense, right? Because a lot of hair growth is induced, hair loss is induced by changes in the immune function in the hair follicle itself. I like using TB4 in combination with strategies like fasting mimic diet because it helps with stem cell maturation. Regulation of VEGF, incredibly important because we get, of course, in inflammatory events like colitis, we get this, elevated VEGF, but in other situations like biotoxin exposure, we get a incredible downregulation in VEGF. Regulation of the metalloproteinases, which of course is important in the connective tissue expression of inflammation, right? So the connective tissue milieu or matrix. And then, of course, if you look at the anti-inflammatory side of things, downregulation of kappa B, downregulation endotoxin lethality, meaning that it reduces the signaling expression of endotoxin, and then decreasing, of course, a host of inflammatory cytokines and improving cytokine anti-inflammatory expression. So promotion of wound healing, incredibly important. We use, Thymosin Beta-4 can be used, I like to use it pre-surgically as well as post-surgically, or if there is an injury, connective tissue injury, incredibly important for, getting that regulation of inflammatory signaling in the connective tissue downregulated. So where's its application, of course, for immune support? Soft tissue repair, I've seen amazing, nothing short of amazing tendon, ligament, and muscle repair, especially when used in conjunction with BPC 157, which we're going to go over in a second. And on pressure or venous stasis ulcers, I would say any type of wound, you will get improvement in with TB4. Immune modulation, so autoimmune thyroiditis, other autoimmune behaviors, but in particular, I've seen some striking changes with BPC and TB4 on autoimmune thyroid. And then, of course, regulating the neuroinflammatory response. So as we activate microglial cells in the brain due to either lipopolysaccharide or TBI or environmental burden, trying to regulate that the oxidative stress burden and inflammatory signaling response of the immune trafficking cells like that, microglial cells. And then also think of it in support for ischemic stroke for protection of cardiac myocytes. So decreases endotoxemia. I would say that chronic endotoxemia is a big issue. So the use in sepsis, sure, we already talked about that, improving that mortality rate in sepsis. But I have to tell you that there's a lot of folks with low-grade endotoxemia, typically either due to dysbiosis or reduced blood flow into the intestine. Of course, as people get insulin resistant, their blood pressure goes up. There's reduced blood flow into the gut, which causes die-off of bacteria, which then releases circulating endotoxin. And of course, the issue of even people with gingival plaque and the upregulation of endotoxin or lipopolysaccharide in that plaque burden in the mouth. Incredibly important as it relates to cardiovascular disease. General dose, typically 300 micrograms, that up to 1 gram daily was in some clinical trials, typically 300 micrograms. Once again, if it's an injury, like say, for example, a labrum or, a knee or inflammation in the hip, obviously there are orthos and docs that are, dropping them in under ultrasound, guided, injection, but just the injection into subcutaneous tissue around, for example, a shoulder. I've seen nothing short of tremendous benefit on healing and repair. I mean, injuries like Liz Frank, where, typically a 12 to 18 month return to play injury being repaired in 5 months. A golfer with double labrum surgeries that was back swinging a club in 6 months when he was told it would be 12. An individual that was a tactical operator that, couldn't raise his pistol, for teaching for first responders because he had such inflammation in his shoulder capsule. And within a few short months, he returns to normal. In particular, combining TB4 with BPC 157. So doses can vary. We're all clinicians. I know you're going to play with these, but if you can start with 300 to 500 micrograms daily for a generalized response, typically at the acute phase of inflammation, we'll do it a couple times a day subcutaneously around the affected area. In our last compound, and last but not least, obviously, this is probably one of the more important compounds that, at least for North America, really revolutionized the thought of using peptides, and that's BPC 157, otherwise known as body protection compound. So it's 15 amino acids. It's derived from the human gastric juice. Very important in terms of the signaling between the gut, the immune system, and the brain, or the enteric nervous system. Obviously, when people suffer from a TBI, that triggers the enteric nervous system signaling to break down the mucosal barrier in the gut, and therefore increase inflammatory signaling via the enteric nervous system back to the brain. as well as the fact of microglial activation, inflammasome activation in the brain. It's cytoprotective. It has an anti-inflammatory effect. And absolutely both orally and through subcutaneous use supports the mucosal lining of the gut and helps to inflame the gut mucosa. People that are on NSAIDs, for example, should think about taking BPC as a protective measure, especially as there any drug that's really affecting the mucosal barrier. Proton pump inhibitors, H2 blockers, even things like if people are on any sort of oral contraceptive, even metformin can affect the mucosal lining in a subset of people. So when you think of, are they having gastric symptoms? Are they having GI symptoms? You want to be thinking of BPC 157. That obviously is fantastic in terms of its healing of connective tissue, post-surgical healing. And then just to give you a quick picture, right? Yes, it's real. The gut does get permeable. In the picture in A, that is a normal mucosal barrier. In C, we see the cracks and crevices in the mucosal barrier. That is known as gut permeability changes, or what people call a leaky gut. This was under electron microscopy. Here on B, we see the cilia, where the tight junctions are expressing, and we note that there's nice tight junctions and a uniform length to those cilia. And then, of course, in D, where they are getting disrupted. This is from a study in 2018, microbiota dysbiosis and barrier dysfunction, and inflammatory bowel disease and colorectal cancer, exploring a common ground hypothesis. So if you think of people that may have elevated VEGF, like in colitis, using BPC 157 to bring people back to that picture in A and B, I think it's an important therapeutic to help with brush border cells. Now, obviously, in addition to BPC 157, for the brush border cells, we want to increase butyrate production. So are they getting enough fiber? Do they have probiotics? Do they have prebiotics? Do they have adequate glutamine? Because glutamine is needed for the enterocyte to puff up and be at its best height, right? So glutamine is conditionally essential in these situations. So what is it doing? It is downregulating several metabolic or meta-inflammatory signaling. It's downregulating TNF alpha, which, of course, when you look at areas like psoriatic arthritis or in colitis, where we have this upregulation of TNF alpha in the gut that's been well defined, it helps with regulation of that. It helps survival of cells under oxidative stress, which, of course, is incredibly important in terms of the inflammaging construct. And then, of course, there's decreases in neuroinflammation. Once again, a lot to get in an hour, but decreasing neuroinflammation, critical, because it's that regulation of microglial cell activation and excitotoxic behavior in the brain, which of course is damaging neurons. And unfortunately, that is a self-fulfilling process. Whereas we damage neurons, we release more neurolaminin, we release more laminin, we trigger more microglial cells because of the aggregation of proteins within these neurons. And so anything we can do to downregulate that, of course, is sparing neuronal damage. So big benefits, wound healing, decreasing, inflammation. I mean, I have a case yesterday, a doc actually who was on a bike and got hit by a car with tremendous inflammatory response. I mean, cognitive issues, a couple different broken bones, connective tissue pain, migraines. And yesterday we had started applying peptides in the last month. And she got on the call with me, and she just reported, I feel like I'm getting back to me. This was after a year of, she was working on her own, trying to do things. And then we started working with her about 90 days ago and, did some ground level things, but then we initiated peptides, and, pain is down, neuropathy was down, her brain felt clearer. So this was a clear, very clear example of the power of BPC 157. So this improvement in nitric oxide and the improvement in fibroblast activity, of course, is going to help with bone repair. And of course, we need that nitric oxide activation because it's going to deliver blood because of the relaxation of blood vessels and the ability to get nutrients deeper into tissues. And then, of course, this expression of VGFR2, which is for regulation of VEGF and the inflammatory signaling in the gut. And this was kind of a fistula model in a rat study showing improvement in fistula after being on BPC through 2 weeks. I always say the next time I have a rat with a fistula coming in, I'm going to be in great shape. But just in reality, BPC 157 is phenomenal when we look at these open type wounds. It helps improve granulation. Of course, I would say add collagen as well. You want a lot of hydroxyproline for granulation. We've already discussed the fibroblast recruitment and collagen formation. There does seem to be an upregulation of growth hormone with BPC 157. I don't think I use that as its primary target. It's just been reported in the research. And the neuroprotection, I'm more and more impressed with it all the time. With its improvement in nerve regeneration. This was a compound obviously used in the one gentleman that I mentioned earlier. It helps with serotonergic, dopaminergic, and GABAergic systems, as well as the opioid system. So there's a global effect on neuronal function. And then being cardioprotective, also, interesting. I don't look at this as my primary piece, but it absolutely, with improvement in nitric oxide, and I would combine this with nitric oxide support, whether you're looking at things like, beet extracts or other nitric oxide supportive agents, aged garlic extract, for example. This can be very effective, in combination with different nutrient strategy targets. Injection, you can either go by body weight. I typically do about 500 micrograms once or twice a day. If you do it orally, it can be done in 500 microgram capsules. And typically I'll start a person with GI issues on one capsule twice a day, or inject about 500 mics twice a day. I know that traditionally you'll see the dosing at around 300 mics. A lot of our educators or clinicians at IPS, we have instructors that all are clinically very sound and treat a lot of people. And I see in general, the tendency is to move that dose up to around 500 mics twice a day. And remember, combining it with TB4 for tissue healing or downregulation of inflammation, incredibly important. And use it for several weeks at a time. You can discontinue it, then restart as needed. I don't necessarily get much BPC 157 resistance. As we talked about the oral capsule, I'm using, if you are going to have someone with corticosteroid injections, you want to use BPC with it together, because the BPC helps the connective tissue to become less friable, right? So that with steroids, we know that there's this kind of drying out effect of the connective tissue, and BPC really helps to, just protect the integrity of the muscle and connective tissue. And we can see pretty dramatic effects from it. I rarely see, a side effect in the recommended dosages. I honestly, with BPC, I can't think of where I've had someone come up and tell me, oh, I got the side effect from BPC. Maybe occasionally someone will say fatigue. I think I've had 1 or 2 cases over the last 5 or 6 years, but that's about it. It is angiomodulatory. So, I do say that, caution in conditions where angiogenesis could be an issue, like tumors, but there isn't any direct contraindication with that. And I want to get to our questions. I know we're a little bit over on time. Do you have any experience using TB4 for burn wounds and chronic ulcers? Yeah, I would use TB4 and BPC for burn wounds as well as chronic ulcers, because you get improved granulation, improved amino acid synthesis, improvement in healing of the connective tissue. So that would be a definite. Let's see. that's the only question that we've got. If anyone else has a question, certainly we can do it. Ryan, anything that you would have to add to anything that I just discussed, or did we cover these peptides pretty thoroughly?
I was just thinking about asking Ryan too, the same thing, because I didn't mention at the beginning that Ryan also, after leaving TaylorMade, started True Diagnostic, which is a epigenetic methylation test that shows biological age. But also, lucky for us, we get to hear about some of the ways that he's finding out that some of these therapies are actually turning back the clock in terms of biological age. And so I really feel excited. Every time I hear anyone talk about peptides, the whole time I get so excited because, well, the whole thing started for me because everything works. Yeah, I need that. I want that. I need that. I want that. And so I know a lot of the docs on this call are like to stay on the cutting edge of therapies and like to have these things for their patients too. So I'm interested to hear what Ryan has to say too. Are you there, Ryan? Is he there? Ryan.
I actually think he's dropped off. He's not on right now. I can see from the attendees.
I think you bring up a good point, and that was the whole purpose of this, is that when you think of metabolic inflammation, you're really thinking about how you're accelerating aging at that cellular level. And, True Diagnostics is a great way through DNA methylation, but also, great insights with that test in terms of immune aging as well. And, this is really where the, rubber hits the road with managing a patient, right? Is when we can start to regulate these big levers that are affecting how a person, first of all, is feeling, but how their condition is progressing. Peptides are invaluable. I just see them, playing an ever increasing role in how we're going to manage patients in, today and in the future.
Yeah, I consider this like kind of the starter pack. That's why I was really glad that you talked about these products tonight, because it seems like every patient that we come across has some level of insulin resistance, immunosenescence, inflammation, gut dysfunction. I mean, you covered it all, so these are really, like, in my opinion, the most important ones that we can really use, to help people, and they work. That's the best thing, is the feedback that we get, just having BPC 157 and Thymosin Beta-4. I've had people write to me and say, like, this is a miracle. I've had this old injury that's healing. My old scar is healing from a guy had pacemaker replaced. And he said his first scar from the first surgery was getting better, so it's really great to have that feedback. And thank you so much for presenting this tonight. And I have to say, this is just a snippet, Jim, as I'm listening to the International Peptide Society certification course, which, by the way, is available for any of the doctors that are, or clinicians that are on here. I'm not a doctor, I'm a nurse, and I'm taking the course because it's really valuable information, to share, not, just as a coach and helping patients, through certain health issues, because it covers not just peptides, but, like I said before, the nutrition and lifestyle part, and this is the stuff that I think is going to be the most helpful for our patients. Like you said, peptides are just a tool, that we can use, but they're a great tool because they're so specific and you get good results. And I have to say, your patients will love you because they will say, like, what else do you have? What else? What other peptides do you have? And they will keep coming back, and the things work. That's the best part. So if there's not, I don't know if there's any other questions in the chat, or if anyone wants to unmute their microphone. Someone said, Kun Rawi mentioned how quickly the result of using peptide. So Kun Rawi, do you want to unmute yourself, and maybe is there anything like specifically about which peptide or the results? Or maybe, Jim, you can answer that simply.
So the question was, how big are the results? Was that the?
How quickly do you expect results?
I mean, in some cases, it's virtually immediate. I mean, I've had people after a few days on BPC notice a big difference in their inflammatory signaling. I literally just had that happen. We injected a guy, my nurse practitioner injected a gentleman in the, his right shoulder in the labrum area because it was inflamed from him lifting weights. And, literally he's texting that night saying, I can't believe how much better my shoulder feels. So it can be immediate. And then, of course, the more chronic a situation like MOTS-C is in that one particular study showed after 4 weeks, there was a significant difference. I wouldn't look, obviously, for someone to have their glucose drop and all their insulin dysregulation, just disappear in a couple of injections, right? It's going to take a little bit of time. but literally you're going to see tremendous changes quickly in general with the use of a peptide in your therapy. And I'm going to lean back on the fact that if we can consider nutrients, consider nutrition, consider lifestyle, the more facets of that individual's health that you're helping to kind of, get back in alignment, then it becomes remarkable, right? You get this geometric progression of benefit because of that. But regardless of that, you see results quickly, sometimes within a few days. Obviously, if you're dealing with an infection and you're wanting to use TA1 to help that, people feel better much more quickly, right? They overcome their viral issue.
Jim, someone just asked, what would be the protocol for knee injection osteoarthritis using Thymosin Beta-4 and BPC 157?
Yeah, so I would start out probably twice a week, and you don't have to do them in the area, but I tend to do them in the area, have them done in the area, right? I have my crew is doing that, and so it would be 500 micrograms of BPC, 500 micrograms of TB4. I would do that twice a day for the first week, see how they're feeling. And then you can cut your TB4 down to say 300 micrograms. I keep that BPC up at 500 micrograms per injection, and see how they're progressing. When they get to kind of a steady state and they notice, significant improvement, you can go down to, once a day, then go down to once a day, 5 days a week. And then, as they're out of that chronic pain, you can get to modulate whether or not they need to do them daily, or whether they're, at an every other day, event, or even twice a week, right? But you start out a couple times a day. And what I do is I basically do the triangle method, right? Injections at the points of the triangle. And then every time I inject, I turn the triangle a little bit. So I'm injecting all the way around that soft tissue. You could obviously do an intra-articular injection if you're skilled in that, or you do that regularly. But honestly, subcutaneous works the majority of the time, unless you're in a really nasty necrotic or acute inflammatory event like a hip, right? Where maybe you need to get right there and drop it right into the area. So that would be the easiest. That's the way to do it. A couple times a day, and then titrate it down as you're seeing improvement.
And the length of time usually for therapy, I don't know about you, Jim, but I found that a lot of people don't need much past a month. I've really only had maybe one or two people that have ever asked me for a second month. They usually start to feel better. But in general, I've heard a lot of doctors that will recommend maybe taking a break after, a certain period of time, like 8 weeks, not longer than that, then give it a break. And they can always use it again. But again, just using caution in some of those conditions, like you said, that you don't want to promote angiogenesis, you would want to not lengthen the therapy quite long. Is that correct?
Yeah. I mean, so once again, I think it depends on what your application is, but, typically 8 weeks on, take a month off, see how a person's feeling and doing. If you're dealing with someone, say, for example, that has an ulcerative colitis, you may need to have them on BPC for, 12 or 16 weeks. And then take a break, just like it said in the slides, take a 2 to 4 week break, evaluate, and either reinitiate, or because of all the other interventions you've done, you've got that person under control at that point.
Okay. One other question is how to follow up, for example, a blood test, et cetera, or follow up only by the clinical problem?
Well, I mean, I think, so you can obviously look at inflammatory markers, right? So if you're, looking at things like CRP and looking at homocysteine, and maybe you're looking at deoxyguanosine for DNA damage, or you're looking at glucose and insulin, for example, kidney function. I mean, TB4 for CKD is incredible. So TB4 and BPC, incredible for CKD. So you're going to monitor the functions that you're targeting. And obviously for me, it's always important, how's the patient feel? I mean, in the end, what we're really trying to do is affect that, because, a patient's going to look at your blood test and you're going to be really excited about the fact, you lowered their fructosamine or you lowered their insulin, and you know what they're going to be excited about? Hey, I lost fat. I'm not tired in the middle of the day. And I'm not getting up at night to urinate. So the aspects of type 2 diabetes, right? So, you know, I question people thoroughly. I want to know everything about what's improved and what hasn't. And then I'm always looking at, you know, various markers. If you're looking at it from a longevity perspective, then True Diagnostics is a great test, right? Because what am I doing to regress that biological age? And, you know, it's interesting because people will say, oh, I've got, you know, I've got bad genes, right? Well, I happen to think that, you know, peptides are one of those things that are going to help us in terms of our transcriptomic effect of how our genes are either getting activated or inhibited due to all of the insults that we have. And you know, I'm a great example. I mean, I've got all the obesity genes, all the heart disease genes, all you name it, and you know, been able to regulate all that stuff over the years. And I think that we want people to understand that, you know, you are in control to a certain extent on that biological clock. You can regress that progression of inflammation. So that's a great test in terms of people that are interested from that longevity or biological age perspective. And then otherwise, they're looking at traditional markers.
Okay. Thanks, Jim. I know that there's going to be probably a lot more questions that pop up, you know, after the webinar for everyone. And so I just wanted to mention that you're always welcome to reach out to us at GenOracle. You know, you can find our website now online at genoracle.com. And we have also a lot of resources available there for you, for your patients. We have downloadable brochures for your patients that give just some kind of terms to your patients about the benefits of the products. And then on the login side, if you would like to create a profile with GenOracle, you would have access to some of the deeper information about protocols or price lists, things like that, because there's a lot of other things that we will talk about with peptides as the months go on, and a lot of other products that we're going to talk about that can be really beneficial to add in. And so this is just kind of a start, and what a great start. Thank you so much, Jim. And thank you, Amy, and everyone at IPS and A4M for supporting us and for helping us get going. And to Ryan, I know he's not here anymore, but he's amazing and has helped us over a year now getting everything going for GenOracle. And thank you to Max Life. Sasha, you're great. Everybody over there for helping us get this started. So any other questions, please let us know. Otherwise, we'll see you again.
Thank you, Nikki. Bye, everyone.
Bye.
Okay, thank you.